I'm really excited to be here at the BMA House Employer Roadshow for Fit for Work, and today I'll be talking about the Fit for Work service, the mechanics and nuts and bolts of the Fit for Work service, how you refer into it, what you get out of it, and hopefully employers will go away having had a fantastic day and be better informed for it.
Ladies and gentlemen, good morning. It's a pleasure to be here today to speak with you. Just by way of introduction, my name is Dr. Sundar Thava. I'm actually a practicing NHS GP with one hat on, and with another hat on, I'm currently supporting the Phil Kirk and HML in the rollout of Fit for Work, and specifically dealing with issues around GP engagement. So that's me. Just by way of show of hands, very quickly, who have I got in the audience? I think most of you are HR managers. Who's heard of the Fit for Work service? And how many of you have referred into it? That's two, I think. And how many of you have in-house occupational health services? Okay, great. So there are, I think, a few issues that we will cover. I will go through the presentation, and hopefully that will give you a very clear idea of what the service is and what is involved. And if anybody wants to raise any issues, I know there are often issues around GP engagement, how GP should better be supporting the occupational health agenda, and difficulties you might have. I'm also happy to take questions and criticisms and challenge on that as well. So you'll recognise the handsome chap in the bottom left-hand corner. He's just been talking to you. Very much, I think, a very novel and exciting thing, certainly from my perspective as a GP, to actually have a service for the first time that talks about providing some sort of national occupational support to the employee. As David has previously alluded to, I think it's approximately 80% of the UK working population work for small and medium-sized enterprises, and therefore by definition have no access to any form of occupational health support. Why is that significant? Because if you don't have access to occupational support, you'll go and see your GP for a variety of reasons, to do with workload, to do with expertise, to do with our regulatory framework and competence to give advice. Most GPs will shy away from doing anything more than treating the immediate medical problem that needs to be resolved, and then they will often tell the person to go back and speak to their employer. And if you are a small organisation with no dedicated human resources facility, no experience of dealing with and managing sickness absence, that's obviously a challenge. So I think it's a very exciting thing. I think it has the potential to do a lot of good. So what I'm going to try and cover in this presentation is an overview of what Fit for Work is, how does it work, and what the potential benefits are to you as employers, to the individual, because I think there are important benefits for the individual, and also to the wider sort of health network, if you like, primary and secondary care. So what is Fit for Work? It's a new service, obviously. It's meant to be a voluntary service, and I think it takes some of the best evidence out there and really tries to put things into context. There is a shared norm, if you like, within society among a lot of people that if you are ill, if you're not feeling 100%, if you are feeling unwell, or if you have a diagnosis like diabetes or cancer, you cannot work. And that often binary rationale, if you like, to fitness, sickness and work is probably incorrect. And there are as many doctors who hold that view, although I'm pleased to say that I think is changing, as there are members of the lay public who hold that view. And I think it's important that one of the sort of, I suppose, strategic, visionary things about the service is it will help to educate and re-educate people about, well, okay, you do have a significant illness, but what can we do to adjust your workplace and maybe your attitude in some cases, and support you in going back to some sort of gainful employment, which we know is better for the individual, better for the organisation, and better for society. So the service itself is a voluntary service, which I think is important. It will be open to people that are in some form of employment. It doesn't at the moment cover the self-employed group of people, but if you have a job and you go to your GP with an illness or an issue, you are entitled to be referred into the service. And it is very much a service that is being delivered in England and Wales, and there is also an independent but mirrored service being delivered in Scotland by Scottish Government. So, as I said, it is there to provide an early intervention occupational health service for people who have not had access to that. And I use occupational health in the broadest sense of the word. It is basically bringing occupational type expertise to the doorstep of this large group of people who have just not had that available. it is very much driven with the employee as the person at the centre of the process. They have to provide consent, they have to buy into it and want to engage with the service. And I'm sure there are strong opinions in the audience about whether that is right or wrong as a settlement goes, but nonetheless that's where we are today. Employers will also be allowed, so GPs can refer on the one hand, but employers will also be allowed to refer. With GPs, if a GP sees a person, whether it's on day one of their sickness absence or later on in the course of that sickness absence, the GP can make a judgment with the patient's consent to refer. For you as employers, generally speaking, we're saying at the 4-week point, if they're hitting that 4-week target point, that's the point at which to trigger the referral if you think it's appropriate and the patient has voluntarily bought into it as well as something that it will be good for them. And that's just a picture of our Chief Nursing Officer, and we can talk a bit more about how the service is delivered in terms of the mechanics. So broadly speaking, there are two elements to the service that you will have access to. The first is the advice line, which anybody can pick up the phone pretty much and call. It's targeted at employees, at employers, and at general practitioners. So if you have an issue, if you have a difficult case, for example, you work for a haulage company and you have a individual that comes in to see you or sees your line manager and discloses to the line manager that they've got a problem with alcohol abuse and they're driving a heavy vehicle around, there are clearly not only implications for the welfare of the individual, possibly implications for you as an employer, but there are also health and safety and public safety issues there, and you might want to take some advice around how you would go about tackling or managing that issue. So you can pick up the phone as an employer and do it. Similarly, as a GP, we often see a lot of diabetes around at the moment, a lot of type 2 diabetes, a lot of people being started on medication which may lower their blood sugar, something called hypoglycemia, and there is a statutory requirement within the DVLA to at least have thought about the risk of hypoglycemia at the wheel. If someone's losing consciousness as a result of low blood sugars at the wheel, that has an impact. So picking up the phone, the GP might phone up and say, look, I'm starting this guy on this. Any advice, any rationale on what happens? And by the way, I think they drive for a living. So useful from that perspective. And as well as the phone line element, there is a website, and I'd encourage you, if you've got a laptop or a tablet or such like, to have a look on it, www.fitforwork.org. It's got a domain for the employer, a domain for the employee, and a domain for the GP. And if you look through that website, you'll be able to see the referral template which the GP will use, and you'll also be able to see on that website the template which the employer will be able to use. So that's quite important. And in addition to the advice element, we've got the assessment element, and that's really the way that you as an employer or the GP can facilitate an individual being referred into the service with the criteria that I've mentioned previously. So at any point in the first 4 weeks, possibly longer for the general practitioner to refer your employee in. For you guys, once you've hit the 4-week point, speak to the individual and decide if it's appropriate and decide if they will consent to it, and then fire off a referral. You fire off the referral, and what will basically happen is that they will get contacted by an individual who is a healthcare professional who has got additional training in occupational health problems and challenges, and they will go through a 45-minute assessment of that individual. And that's very much a therapeutic assessment, I think, from what I've seen of it. It is very much trying to identify barriers to that person being in employment, sustaining their employment, assuming their medical problems are relatively stable, and trying to say, well, look, how can we work with you and your employer to facilitate getting you back to work? And we can talk a bit more about that in detail. The end product of that whole process is the return to work plan, which is a detailed plan which is given to the employee for them to own, not for the GP or the employer to own, for the employee to own, and that will have positive suggestions on things they may need to do to facilitate their remediation, if you like, back into work. Some of them may be employee focused. For example, if their wife is about to leave them, as I think David alluded, those complex problems that are happening in their personal lives, their wife's about to leave them, they're in debt, and they're being bullied at work. They may have advice on going to a debt counsellor, for example, and we would signpost them to that. They may have advice on she's gone out of my mind. So we talked about debt. What was the other thing, Phil, I said? Marriage counselling. They'll be signposted to marriage counselling, and at the end of that process, there may also be a liaison, if it's deemed appropriate, between our assessing health professional and the employer to say, look, guys, there are some issues around bullying at work here. Could we look at how we address them? So the patient owns the return to work plan. They decide what to do with it. It's entirely up to them whether they want to share it with you as employers and with us as the general practice community. But my view is, generally speaking, if a person's voluntarily gone and engaged with the service, there is no reason why they should not want to do that. So a bit more about how it works. This is a very useful flow chart. I think it's in all of your handout packs. It details in very simple and easy to capture terms what that journey is going to look like. I encourage you to use it. I'd also encourage you to circulate it within your organisations to your workforce, because although GPs are supposed to be doing the referrals in the first 4 weeks, certainly, there's nothing stopping you as an employing organisation counselling your person who you identify issues with to go and speak to their GP. And in fact, I would almost encourage that, because the GP is seen as a neutral broker in these things. You as employers may not be. GP is seen as a neutral broker. If you can have a supportive conversation, as most HR departments would have, I hope, with their employee about difficulties, there's nothing stopping you from saying, look, we realise there's some difficulties here. Have you heard about this new service? Because often many people will not have. You might benefit from it. Maybe you want to go and speak to your GP about it. And giving them a printout of something like this to take along with themselves to the GP, because one of the challenges that we have is trying to make sure all GPs are tuned into this programme. We're working very hard to do it, but there are a lot of GPs out there with a lot of other competing problems and issues who may not have heard about it. So you can empower the GP, you can empower the patient, and hopefully you can speed a resolution to the problem before it gets any worse. Now there is a video which is supposed to summarise what I've...
Every year, around 1 million workers are off sick for at least 4 weeks. And without support, many will not return to work at all. And that's not good for anyone. Fit for Work is a brand new voluntary scheme that gives access to occupational health to support people back to work. And what's more, it's free. It includes an advice hub and a referral service. And it's backed by GPs and employers, a service that works for everyone. So how does it work? Well, let's use Bob as an example. He's been off work for 4 weeks, losing earnings and worrying about getting back to work. There are 2 ways for Bob to access Fit for Work. He can be referred either through his GP or his employer. Either way, within 2 working days, a Fit for Work health professional will give him a ring. Bob chats about his health, but also his other concerns. A Fit for Work assessment is made, and further help is signposted. Already, Bob is starting to feel more supported. They both agree on the best solution. After all, nothing happens without Bob's consent. The result is Bob's own individual return to work plan. He then agrees to share his plan with either his GP, employer, or probably both. With a step-by-step approach, they all agree to help him with his return to work plan. With close support from his Fit for Work health professional, GP, and employer, Bob gets back to work. That's Fit for Work in action. Good news for Bob, supporting him back to work more quickly. Good news for GPs, saving them consultation time and supporting their patients. And good news for employers, they get their valued workers back sooner. For more information, go to the website fitforwork.org or call the advice line 0800 032 6235 or speak to your GP or employer about being referred into Fit for Work.
Beautiful. Hopefully that helps. Just to say a bit more about the service itself. So the service employs registered health professionals to actually deliver the assessment element of the service and also to support the advice line element. You guys may talk about financial governance, corporate governance within your organisations. Within clinical circles, we often talk about this thing called clinical governance, which I think is essentially the same sort of thing. There are established standards of what is deemed good practice within occupational health and wider medical practice. And you can benchmark those standards, and it is possible to audit people's performance against that benchmark standard. Now, clinical governance basically means that everybody going through the service will speak to one of our people, and the output from that consultation will be reviewed regularly by our panel of senior clinical people. So that's our medical director and our chief nursing officer, among others. And what they're trying to do is they're trying to ensure that whether you're referring from the north of Wales or the south of England, that whoever that individual coming into the service for assessment, they're all getting the same sort of treatment, same sort of advice, the same sort of access to the right sort of information, and that there is a consistent standard across the board. And I think that's very important to highlight. The assessment itself uses this biopsychosocial model, which a lot of people are talking about at the moment, because what we are often seeing in clinical practice is that when a person who is in employment is having a wobble, very often they do not have a classical, what I would call a pathology, a medical problem in the way that I would have been taught about at medical school. And this is widely recognised. I speak to GPs across the country, and more GPs are having a growing list of people with chronic problems, but actually when you unpick those chronic problems, there is no identifiable pathology. They will have seen every specialist under the sun for their chest pain, for example, and actually all the tests, all the scans, all the investigations, all the expert opinion is essentially normal, yet that person has a very real perception of pain, and that has resulted in them falling off the employment ladder, often falling into long-term sickness. So there is an issue around how we reconstruct that, and I think what this approach actually demonstrates, and what we as GPs used to do when we had the time, was try and unpick that person that came in with a headache. And of course, most people, with a headache that's persistent will think, I've got a brain tumour. People always think the worst thing. You unpick that, and actually what you realise is that there are welfare problems, marriage problems, relationship problems, difficulties at work, which are not clinical. And if you've got the time, we talk about the doctor as a drug, the therapist as a drug, there's a whole literature on it. If you've got the time to unpick those issues and challenges, which our people do because they've got 45 minutes to do it, you can hopefully come to some resolution. The other thing is people are not always aware of things. For people like me, I have a very detailed awareness of what welfare and support services there are, both within the NHS but also without the NHS. All the charitable and third sector organisations that provide very useful, valid information and support. But for Joe Bloggs, who has been working in a totally different sector of the world, understandably, they will not have that understanding. So, and you guys as HR professionals probably have a better understanding than most of these sorts of supporting issues. But if one of the things that we can do is provide high quality signposting and advice to people at an early stage, and that will definitely have an impact. And if we're thinking about all these other problems, not just the medical diagnosis bit, then I think the chances of actually achieving good resolution are strongly in our favour. So I'm sure you all know this. If you are able to keep people in work and keep them happy in work, they are generally healthier. If they are healthier, they will be more productive, and if they're more productive, the cost to your organisations in terms of recruitment, retention, sick pay, absence management, fees for lawyers, for tribunals should all be minimised. So I think there is very much a very strong buy-in. I think most people in the HR realm are bought into that. And best of all, this service is free, quick and supportive. I realise there may be some questions which very much relate to how does it integrate with my existing OH service, and we're happy to, I'm sure we'll either take it as a panel discussion or if people want to approach us afterwards, please do. Just to reiterate, the Fit for Work plan is a step-by-step plan. It is saying to the individual, this is where you're at now, this is where you need to get to. We're not forcing people, we're not coercing people. It's very much saying, this is where you are, this is where you need to get. These are the things that would possibly help you to get there. And if you do these things, then you're more likely to get there. And just as a byproduct, I work for HML, which is delivering the service. We have a history as an occupational health specialist, clinically led specialist organisation. We use things like telephone based assessments and triage and such like. We use this process of regularly contacting people, and commercially it works. We get good results with that. I think this is based on a very similar model, so there's no reason why it shouldn't be working for you as organisations and individuals. And I think this slide just basically says people want and are asking for help. Employers are asking for help. Employees are asking for help. If we get in there early and if we do our stuff in the right sort of way, we should be making positive impacts. And then I think this slide really covers how this might fit into existing OH services. OH services are increasingly being subcontracted out, because I know, because again, HML, we deliver a lot of subcontracted OH services to other organisations which used to have their own in-house. They can be expensive. There is a role, I think, in just to go back one, and they can take time to get people referred into, depending on what your internal sickness absence policy is. And I think there is a role in looking at your organisational sickness absence policy and looking at potentially using this as a triage service, particularly with the people who you have an inkling have not got serious underlying medical issues, but you suspect there are lots of other things going on. Because we know that, as David Frost has said earlier, if you get to people earlier, and I've heard work quoted from Spain recently, which says in the first week, if you're getting people who've gone on to sickness absence back into some sort of engagement with you and with these sorts of services, you're more likely to get them back. And OH can't always do that for issues of capacity, among other reasons, as in-house OH can't always do that. So fire it into us. We've got a performance indicator to make contact with that individual within 48 hours, and if they are happy for us to proceed, we would then proceed to produce that return to work plan, agree a return to work date, and as I've already said, just doing those things will statistically increase the probability of that person going back into some sort of gainful employment. But just to reiterate, also, we are not a replacement for occupational health services in complex environments. If you, for example, work in an industrial setting, if you work with radiation, lead, asbestos, where people are exposed to toxic substances, there are statutory and regulatory requirements which you will, I'm sure, all be aware of, which require you to monitor the health and welfare of your workforce. And this service will not supplement that, and therefore there is a role for paid for occupational health services. But I think working in parallel with this, give us the stuff that is the low fruit, as it were, the low-hanging fruit, which is stuff that we could easily potentially resolve, and leave the complex cases, and also the long-term sickness cases. If you have general sickness absence policies and people are away for long periods of time and have complex medical issues, leave those to the OC Health, paid for occupational health, consultant-led services, and think about using us sort of in parallel. So I've already reiterated this. I think really going back and looking at your approach as an organisation would be helpful. This service is out there now, it's free. Am I going to use it? How am I going to use it? How will I disseminate this information, not only among my HR cadre, but also to my line management, the people that are managing the employees, and how do we support them, as in your line managers, in operationalising this. And I would also engage your employee workforce in it, because as I said to you earlier, if your workforce is aware of this, then they can act as a push to initiate things and take the initiative. I think it's wrong. I think sometimes, certainly in some of the discourse that you hear and read about fitness and work, there is an impression that everybody that is on a sickness absence is malingering, which is probably the wrong that wrong norm. I think starting from the approach that somebody has a genuine problem, be it a physical problem, a mental problem, or a perceived problem, how do you unpick that? I think engaging line management early, engaging the employees early in that process will do a lot to facilitate that. That's just a illustration of the referral template, which again, if you've got your iPads here or your iPhones here, I'd encourage you to have a look at www.fitforwork.org. And that's a bit more about where the service is. Basically, as I stand here today, the service has been rolled out across the entirety of England and Wales, and there is a mirror service in Scotland. We are taking referrals from GPs, and we're also taking referrals from employees. So we are good to go. And there is loads of collateral. The website has loads of stuff you can print out. That flowchart I showed you was one of them, but there's lots of other stuff. There's policy documentation on there, other things you may want to go and consult. So have a little scoot around on the website and see where you're at with that. I'll end with that. Fit for Work is a line of support for GPs, employers and employees to help people back to work. It's free, use it, take advantage of it. Have those communications with your primary care community. Write to them. One of the professors of occupational medicine says write to your GPs, set an expectation, and I'll end there. Thank you.